Welcome, Gyno-Curious listeners. I am Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. Today, I am thrilled to be speaking with Dr. Lisa Curcio. Dr. Curcio joined Nuvance Health to establish a breast surgery program at Northern Dutchess Hospital in Rhiniecliff. She came from Memorial Care Medical Group and was medical director of surgical services at BreastLink in Laguna Hills, California. She specializes in both oncology and breast surgery. Dr. Curcio completed a surgical oncology fellowship at City of Hope National Medical Center in Duarte, California, and a general surgery residency and internship at George Washington University Hospital in Washington, D.C. Welcome, Lisa. I'm thrilled to have you today.
Thank you for having me.
Pleasure. Please share with me, how is it that you went from a general surgery residency to becoming a breast cancer specialist?
I think like a lot of people, I was influenced by events that happened in my younger life. My grandfather died of pancreatic cancer when I was in 5th grade, and he was really the patriarch of our family. So initially I was going to be a nurse, and then I did some candy striping and decided I wanted to be the one giving the orders, not taking the orders, and thought I was going to be a medical oncologist till I did my general surgery rotation. I really found surgery fascinating because there was that instantaneous result where someone comes in with appendicitis and you take out their appendix and they get better really quickly. But then I had to figure out how to meld that with my want to take care of cancer patients. And one of my mentors directed me to surgical oncology. So that was a well-developed field that was really budding at the time I was in my residency. And he encouraged me to apply for a fellowship. So initially, I was a surgical oncologist doing all general surgery, and my passion was pancreatic surgery at that time. And then after I finished my fellowship, I had a health profession scholarship, and I was in the Air Force doing my payback time, and I got diagnosed with breast cancer. Diagnosed my own breast cancer, as a matter of fact. So it took me a little while after that, but then I finally decided that as the field was really blossoming with more treatment modalities and more surgical options, I decided that I really wanted to focus my future practice just on breast cancer oncology. That's where I got really very focused in my practice.
What a journey.
Yes.
I've met many physicians and clinicians who have experienced cancer in their area of specialty. An ophthalmologist with melanoma of the eye, gynecologists with ovarian cancer, and here you are, a breast specialist, perhaps before or after your own diagnosis of breast cancer. How does that shape you? How does that inform you as a clinician and as a woman practicing in your field?
I think humbling as a physician to be on both sides of the table, both the deliverer of the diagnosis and the recipient of the diagnosis. I can say it was a very emotional time when I was diagnosed. As you can imagine, I was 37, I had a 9-month-old child. I was just starting my career. I felt like I spent my whole life getting to this, what I thought was my mission, and then maybe being robbed of a future in that. And so that was it was a bitter pill to swallow. But eventually I picked myself up and put my big girl pants on. And I think for a little while, I didn't decide to specialize after I was done with my breast cancer treatment for another several years. It took me a little while to realize that this was really my calling. This was where I was meant to be. But it was a difficult road to navigate because in the beginning, because of my cancer and because of my age, I decided I had to have a mastectomy on the cancer side, and I chose to have a preventative mastectomy on the other side. And I didn't want to tell patients that I had bilateral mastectomies because I was afraid that if you did that, then that's what I need to do. I was afraid it would bias them. So in the beginning, I didn't tell people about my cancer diagnosis, but then I realized I needed to share, and I need to share why I made those decisions. And that if I was diagnosed at a different point in my life, I might not have made the same decision. So they were really driven by where I was in my life at that time. And some of my patients that knew me before I came out of the closet about my breast cancer, said to me, I was really mad at you in the beginning when, you didn't tell me when you first met me. But then I realized like that tug and pull that you actually had, not wanting people to be biased by the decisions that you made. I think overall, patients find that talking to someone who's walked that walk is really encouraging. And now I'm 22 years after my diagnosis, seeing someone who's on the other side of that and flourishing, I think is really important for patients.
Certainly in my world as an OBGYN, as a woman taking care of other vulva havers, there is something to be said about empathy and sympathy and identification that just gives us a nuanced, different understanding of the body, disease processes that someone who might not have that anatomy. And I'm not saying that we all have to experience the diseases that our patients have in order to be empathic and sympathetic. But there is this morsel of understanding and insight that is quite profound if you have, in fact, gone through the disease yourself. Moreover, the medical world is such a morass. So it's so lovely to be able to speak to someone who's been through the appointments, the doctors, the surgeries, the chemo, the whatevers, and be able to understand not just how you do it logistically, but the chaos that it creates in your world, your personal life, and how to maneuver it. So I think it's extremely generous of you and brave, too, to share it with patients, because certainly in our training, we're taught that we are not to share personal information. And I think, quite frankly, that's a remnant of the patriarchy. And that when women clinicians share some of their story, it just builds community, which is part of why I'm here doing this podcast.
Exactly. I think women in general, and men too, because men get breast cancer too. The majority of patients I do treat are women. And when they see that you've gone through something that they're going through, there's just this connection that you can't achieve as a physician if you haven't gone through it. And like you said, not to say that everyone has to go through every process, but it just provides a perspective that you really can't imagine unless you've been there.
Yeah. So humans have known about breast cancer for a very long time. There are descriptions of breast cancer dating back to the medical texts from 3000 BCE. In ancient Greece, people made votive offerings in the shape of a breast to the god of medicine. And Hippocrates described the stages of breast cancer as early as the 400s BCE. So over all this time, have we done enough research to understand why this disease is so prevalent, affecting 1 in 7 women?
The short answer is no. But I think we have come a long way. Hippocrates felt that breast cancer was from an imbalance of biles. And now we understand that it's cells that have gone rogue, and we've identified genes that can tell us, the BRCA1 and 2 gene of patients who are susceptible to their cells going rogue because their suppressor cancer genes are not working properly. So I think we've come a long way. I think we have a ways to go. I think we've developed tests to diagnose it earlier. And when you get, for instance, a diagnosis based on a mammogram and you don't feel a lump, the survival's over 95%. So I think we've come a long way, but I still think we need to question why certain subpopulations are at increased risk and, why the risk is still prevalent despite our knowledge and what we can do to prevent it.
So you brought up an issue that I wanted to talk about, this concept that breast cancer doesn't just affect the woman, but potentially her progeny and her family in many generations. How do you help families deal with this kind of information? Because it can be very intense to learn you have a gene that increases your risk of breast, ovarian cancer, for example. And you're, again, not just telling your patient, but your patient's daughters, your patient's granddaughters, etc.
Yeah, I think that's probably the most empowering thing if you look at it as such. Some people don't want that information. But I think the vast majority of women who have significant family histories, they don't want to just wait around for that shoe to drop. They want to be proactive. So I see a lot of patients who seek someone like myself out to be preventative and to talk about what they can do to reduce their risk. And there are lifestyle factors that we can discuss. and things that maybe they need to avoid to reduce their risk. And of course, if their family history is really compelling, genetic testing. And nowadays, not just genetic testing the patient in my office, but getting their family members tested. And there's direct-to-consumer companies that do genetic testing now. So it's really made it much more accessible to test grandma who's 85 and doesn't get out of the house much. We just send it, we have a test kit sent to our house and she spits in a little tube. And a month later, we have genetic test results. So that can be very, very powerful because if grandma has a gene and then we test the patient that's in my office and she doesn't have that gene, then all of a sudden that family history becomes not important for that particular patient. So that can be very empowering.
Do you find that most women are saying yes to genetic testing or no?
Yes, I think that it's easier to test someone who has a family history. Some of our patients that were treated maybe 10, 15, 20 years ago, I think it's harder to get them tested. Sometimes they're just like beyond their cancer diagnosis and they don't want to open up that Pandora's box. Because let's face it, if someone has a gene that they're passing to their children and their grandchildren, there's a certain amount of guilt associated with that. But what I always talk to my patients about is they should not feel guilty. They got the bad deck of cards themselves, the bad hand of cards themselves. They inherited gene from their parents that predisposed them to pass it on. But by identifying it, we can potentially prevent future cancers in their progeny. And you can even go so far as women who are known to have a BRCA mutation can selectively choose to impregnate themselves with embryos that do not have the gene, so it stops in their generation. Now, that's a very controversial issue, but that's where our technology is nowadays. So we can move forward knowing what the risks are, and we have choices whether or not to pass that gene on in some instances.
So you mentioned screening, you mentioned lifestyle changes. Let's just talk briefly about what the current guidelines are around radiology, mammograms in particular. What do you tell women is the appropriate screening approach?
Yeah, I think there is a lot of confusion. Even physicians oftentimes ask me what's the best approach. And I do, in our society, the American Society of Breast Surgeons, we firmly believe women should start screening at the age of 40. And they should get yearly mammograms. And that's the average woman. It's very important to realize that all of these guidelines that people hear about is for someone who has no family members with cancer. If you have a family member with breast cancer, you might need to start screening even before the age of 40, depending on the age of diagnosis of the people in your family. Again, knowing a history, the people that were diagnosed, it's unfortunate, but a lot of people don't know their family history. We're a very transitory society nowadays, and they're not close with their second and third degree relatives, and they don't know a lot about their family history. So I think it's really important to get as much information because there's more and more diseases we know have genetic predisposition. But going back to imaging, mammography is the best test that we have to diagnose cancer at its earliest stages that it can be cured. And so we firmly believe that mammography, and in women who have dense breast, it should be mammogram combined with ultrasound. And then women who are at increased risk should see someone like myself because they might need additional imaging like breast MRI.
So do you think that 20 years from now, 30 years from now, we might look back at the current treatments and think that they were too invasive, barbaric even?
I do think so. I think we look back what we were doing 20 or 30 years ago. People were getting radical mastectomies. It was maybe a little more than 30 years ago. But in the past, and now the majority of patients get lumpectomies, breast conservation therapy. When I had my breast cancer in the year 2000, I had a lymph node dissection, and we rarely do lymph node dissections. Now we do a more intricate procedure of sentinel node mapping and just removing 2 or 3 lymph nodes to determine whether the cancer spread to the lymph nodes. So I think even over the past 2 decades, breast cancer treatment has become a lot less invasive. We're not treating people with chemotherapy that, just have a tumor over a ½ inch anymore, or because they're young and premenopausal. We actually send the cancer for a test to determine whether the cancer has the ability and whether it will benefit from chemotherapy, has the ability to spread outside of the breast. Yeah, I think the more we know, the less invasive cancer treatment is. There's selective patients after a certain age that we offer no radiation therapy if they have a lumpectomy. So I do feel the more information we have, the less invasive the cancer treatment is. And we have better modalities of treatment. Chemotherapy is so much better now than it was 30 years ago. So, yeah.
Astonishing when you look at the arcs in medicine and what we do learn about, what we don't learn about, and what issues are given attention and others that are not discussed. Thankfully, breast cancer has become an area of interest in the world of science and money, allowing for more and more investigation, which I think is contributing to these changes and improvements in treatments, investigation, and understanding of the genetics for sure.
Absolutely. All the advances that we have in breast cancer care are because research dollars and clinical trials, and women that had breast cancer and chose to go on clinical trials to help us figure out whether treatment B was better than treatment A. And all of those advances have taken many years. I think we've gotten better at being able to advance treatments in a shorter period of time nowadays, but it's because of the awareness of diseases like breast cancer that we've been able to make those advances.
So I want to just shift a little bit. In my office, I talk to women about sex a lot. And when I ask women who have had breast-altering surgery or treatments for breast cancer how they're doing with regards to sex, they often say that they feel less feminine or that their partners have never even seen their chests since their treatment. Are women speaking to you about these concerns?
So it's very interesting. As a female, I get more patients who talk to me. But overall, I would say if you don't ask the question, they're not going to volunteer the information. And it is very sad to me when I see breast cancer patients that we have this conversation and they said, since I've had my breast surgery, I haven't been intimate with my spouse and it's been years or it's been a while. And especially if they had a very active, intimate life prior to their diagnosis, I feel like that's been a big loss. And I think it's an area that's being increasingly addressed in our survivorship programs. And there are more things out there and available for patients, I think, to help with that. But I think it's an area that still needs some research. And we need to really, I think 40 years ago, we were happy when people survived. Now we're dealing with 4 million breast cancer survivors. And now we need to figure out, have we made their life worse after breast cancer? And if we have, and there are some long-term effects to some of our treatments, then what can we do to make that better? I think that really needs to be a focus moving forward.
Yeah, I like that you've pointed out how our perspective has shifted as clinicians. At one time, it was all about, oh, aren't we great? We've allowed this woman to survive.
And we should be happy for them.
And we should be happy for them. And now, one, because the treatments have improved and there is this long life ahead of many of these women, what is their experience being breast cancer survivors, amongst other cancers that affect the body and a feeling of sexual health and sexuality? Yeah.
Right.
And it's true that it's about asking the question. The International Society of Women's Sexual Health has done many studies looking at how many doctors will ask the question of, are you having sex? Is your sex pleasurable? Do you have any concerns? And when these studies are done, we're talking about maybe 15%, 20%, 30%, maybe doctors across all fields are asking women and men whether they are in fact involved in sex and how it's going for them.
Right.
So I'm so grateful that women in your practice or women in your office are bringing it up, and hope that future residents will be trained to ask this question as often as they ask, is there cancer in your family? Is there diabetes? Is there hypertension? And the next question is, are you having sex?
Right.
And knowing how to deal with it. But there's a lot that goes on in that conversation, not just with the patient, but of course with the clinician.
Right. And, unfortunately, many of the very effective long-term treatments we have for breast cancer lower estrogen levels and create a very hostile environment for intimate and sexual encounters. At one point, In my office in California, we had all kinds of samples of different kinds of vaginal lubricants, and we had some of our patients that would give us feedback which ones work best. But I do think it's a field that needs a lot more research, whether things like there are some hormonal products like DHEA, and whether or not that's safe in breast cancer patients. So things that we can do moving forward to make things better.
Absolutely. And I think that we are going to talk about this again for sure. My last question is just that sometimes working with the cancer diagnosis day in and day out can be quite overwhelming. What keeps you going? What allows you to continue your practice and make sure that you are both healthy in mind and body?
So I think I'm very blessed in that right now we do cure a large percentage of our breast cancer patients. But I think there always are those cases where people die young from breast cancer and it just doesn't make a lot of sense. And it can be easy to get down and really not get the satisfaction from what we're doing day in and day out, those people that we are taking care of. But I do think that focusing on the future and prevention and maybe a future with less cancer diagnosis, if we can modify, because we know a lot breast cancer is related to lifestyle, and really altering that. We can talk to we're blue in the face, but until people are ready to really make that change, it's like getting a smoker to stop smoking. Until they're ready to make the lifestyle changes, we're still going to see some of these cancers that are lifestyle related. So I think focusing on the future, I have a daughter and I want to be able to bring her a future where she doesn't have to worry so much about being diagnosed with breast cancer because her mom had a premenopausal breast cancer.
Yeah, that it reminds me that we're going to have another conversation about lifestyle, but we are coming to a close. And I wanted to thank you so much for joining me. I am so grateful for your willingness to share your own story with our listeners and with me. Thank you also to my listeners for joining me as we venture into the limitless conversations about our bodies and the world of OBGYN. I would love to hear from you. Please email your questions and comments to comments@radiofreerhiniecliff.org or call us at 845-307-7446. Also, thank you to my producers, Jen Hammoud and Matty Rosenberg. Until our next conversation, stay healthy and stand strong in your knowledge and your insights.